Okay, so everyone loves a bargain, and we're surrounded by statistics and percentages on a daily basis, and some of you might even use them as part of your work. But for the person that doesn't, their effect on our lives can go very unnoticed. Of course, we can all recognize a percentage discount off of something nice that we want to buy for ourselves, but if you're like me, most of the time you'll probably be found standing in a shop looking a bit bewildered with your bad maths and your phone calculator out trying to figure out what the price is going to end up being. But what if that end price is your life? What if you're sitting in front of an oncologist and you're 33 and you find out that the chance of your cancer reoccurring is somewhere in the region of 35%? You have 3 young children, very young children, and you're completely dumbstruck. How would that statistic sit with you then, and how would it affect decisions that you made about your treatment going forward? Well, for me, with 3 young children, it didn't sit very well at all, and I wasn't reassured by the fact that it was just a statistic. Okay, it could represent what would, it didn't represent what would happen to me, but maybe what could happen to me. But I had to take a very personal view on it because this was my life and my family and my future. And when you're newly diagnosed, it can be very difficult to have perspective. Nobody learns about any of this cancer stuff before they become a patient. I mean, why would you? Why would you want to know anything about that world? I mean, maybe it's not so taboo anymore, but it's still not something that the general public delve into unless they're thrown into it. And the transition to oncology patient is swift and difficult. Now decisions weren't just about which dress was going to be cheaper for me, but working out which information was most relevant to make the right treatment decisions that would help me have the best chance of survival. But back in 2004, that statistic on reoccurrence was the only thing that I had to work off of. And I was very aware that if I progressed there and then, there would be no other effective treatment options available for me at that time. I desperately just wanted to stick my head in the sand like an ostrich, and until somebody told me that everything was going to be okay and I could get on with my life again. But I had to accept that that wasn't going to be reality and do something proactive about it. I'm glad, even though it was difficult for me, that I asked for information about treatment options at that time. I made the decision to participate in a randomized trial for an adjuvant treatment because my other option was to watch and wait. And even though that was the control arm on the trial, I knew that I would be seen more often, and for me that was reassuring in itself. And I ended, if I did happen to end up on that arm. I'll admit I didn't do much research at that time on the trial, except to ask a friend who had some vague research experience, and I had no idea about the phase 1 or phase 2 results. I largely relied on my oncologist to guide my decision, because I'd also frightened myself by asking Jeeves, as this was pre-Dr. Google, and pre-me knowing how to use the internet effectively for information relating to my diagnosis. So I signed the consent and I thought a little more about it. But unfortunately, that trial closed early because it wasn't showing efficacy, and I was devastated. So I hadn't reduced my reoccurrence risk to the best of my knowledge, but I had learned a valuable lesson. Trials weren't always successful, and to be careful what I consented to. I was learning what it meant to be an oncology patient. Although years passed from my initial diagnosis and statistically the odds increased in my favor, we all know melanoma is sneaky, and so after more than 10 years and with a now potentially reduced risk, maybe somewhere in the region of 10%, it did decide to reappear. So back then, in 2015, I had limited treatment choices again. I was incredibly ill, and I wasn't even aware of these figures, as I had tried to move on from melanoma in the intervening years. So again, I was in really unknown territory. But fortunately, I was assigned an oncologist who again specialized in melanoma. And please make sure the one that you have that is treating you does specialize in melanoma. My choices were limited, and they were guided again by his advice. I could pick IPI, that was the only drug of its kind reimbursed at the time, and we knew it would take a while to work. But to be honest, I wasn't guaranteed that amount of time left to find out if it would, so that obviously wasn't my preferred choice. Its side effects were well known, and they're not very pleasant and usually permanent, but if it worked and kick-started my immune system, there was this small percentage chance I might even be one of the lucky ones and have a complete response. And let's face it, we all cling to those kind of hopes when we're faced with the desperation of having metastatic disease that can't be removed surgically anymore. The other choice was the newer treatment. And if my biopsy results showed that I had a BRAF mutation, I could take the targeted therapy combination. It was fast-acting, but it doesn't reprogram the immune system, and it's not considered a cure, but more of a temporary solution. Although that idea has changed over time as more data became available. It was a very tense time waiting to find out my results. But for me, fortunately, I was BRAF positive, and the targeted treatment worked exceptionally well. Beginning with a very poor prognosis, I'm now a long-term responder, and it wasn't something that I could have ever have envisaged over 3.5 years ago. Of course, over the course of that time, the trial options and treatments have come my way in the last 3.5 years, and I've looked at the data and made my decision for staying on my present treatment, always based on the data. At times, of course, it can all feel like a bit of a gamble, but armed with statistics from trials and learning where to access the right information, I can make educated, informed decisions weighing up the risk versus the benefits of treatments. And I can see exactly the adverse effects possible with each treatment, the response rates, the progression-free survival, and the overall survival. This data is vital, and it's so important for a patient to be able to understand it. I also learned to be very careful what I consented to, because it could exclude me from something better in the future. And my life now depends on those decisions. Maybe that sounds a little melodramatic, but those who don't understand it, but it's really the reality of living with stage 4 disease. I've met many patients who do not understand the process of trials, the different treatment options, or the expected responses. Some were even on palliative treatment and didn't even realize it. Information, it can be scary, but at least you can work with it and make decisions based on how you want your life to be. If you don't keep yourself informed, you give that power away to other people, and you may end up in a situation you never wanted to be in. We need, as patients, to take some ownership of our healthcare choices. In all other aspects of life, we would not be such backseat passengers in the decision-making. If we were picking a new car, we would research different makes and models, weigh up all the possible benefits of each one, and then decide which one we were going to buy. It should be the same when it comes to our healthcare treatment choices. Many of you will be familiar with this concept of double-blind unrandomized trials. They're seen as the gold standard of research, but are they always the gold standard for the patient who participates in them? We all know randomization means a gamble which arm we will get. And advanced stage oncology patients, we're pretty desperate people by nature, but maybe we aren't as altruistic as other stakeholders think we are. When given the opportunity to join a trial, a patient is looking for their best option. We don't do it to prove a hypothesis for the researchers. The risk of randomization to the trial arm that offers no additional benefit isn't always clear, of course, and it might turn out to be the new therapy, or it might turn out to be the usual standard of care arm. Randomization is one of the biggest gambles you might ever take, and you want to have as much information as possible before you commit to it. Access to treatments you wouldn't otherwise get when you know your life is in danger is probably the biggest bonus for a patient joining a trial, followed closely by something that will improve survival beyond what we already expect it to be with current treatments. But quality of life and extra monitoring is also a hugely important factor for patients. Remember, there's nothing wrong with thinking, what's in it for you as the patient? No one wants to be a dead hero that's too expensive a price to pay just to be altruistic. Ask the questions directly. What is in this for me? It's not selfish, it's survival mode. Of course, understanding what benefits are important for the patient is the best, and it should be the best starting point for any research project. They should always have their opinions taken into consideration, but they do not do this routinely when writing up trial protocols. Opportunities do get missed to gather information that's relevant to the patient and not just to the researcher. Patients need to have trust in the clinical trial process to commit, but we witness constantly the cherry picking of patients to suit what the trial protocol wants to prove, rather than what is happening in the real world to us, the patients. Finding out retrospectively that brain metastases or another comorbidity was unjustified in its exclusion is reprehensible. These treatments will end up out in the real world for people with real world problems, the people being excluded from the trials, the people who could possibly have benefited if the trials didn't cherry pick. The clinical trial system should reflect what is happening in the majority of patients and not just the ones that are more likely to produce good statistics for reimbursement purposes. There was this story about two young American cousins who were diagnosed with metastatic melanoma. And it started a huge debate on trial ethics and what was the best way to collect information needed to provide the efficacy for treatment. Both cousins developed melanoma in their early 20s, and one cousin was randomly assigned to the drug arm of the trial. The other one to the standard of care arm, which by then it was already known that it was not effective. This is what his mother had to say. The poignant pleading words of her trying to access a drug she knows might give her son a better chance of survival were damning of a system that is not always about what's best for the patient, but what's best for data gathering. This mother had seen the treatment work in her nephew, while her son struggled on a treatment that had been the only option, but highly ineffective with years. This scenario should never be repeated in cancer care, and it should give any cancer researcher pause for thought when designing a trial. They need to consider, would they be happy to be randomized to either arm themselves, or let a member of their family be randomized? Is there a better way to gather data, perhaps even using historical data from previous trials as control arms? It's the reason patients need to have a strong representative voice to hold other stakeholders to account. This mother lost her son shortly afterwards, and his cousin lived a further 5 years. Valuable time that was gained for him and his family. We don't want any more patients progressing on poor comparator arms or only getting to cross over when it's already too late, if it's even an option to begin with. I'm just going to mention a little bit about this because it comes up all the time in patient forums. But we've never seen before cancer patients being so bombarded in the media and now social media by claims of miraculous cures, everything from broccoli, baking soda, berries, and restrictive diets. The fact is, patients will try almost anything in pursuit of a cure. And while eating pounds of broccoli mightn't do you any harm other than some extra wind, there are many who would claim what they recommend does cure you. But it could actually end up harming you or interacting with your approved treatment. I wouldn't ask my oncologist for advice on repairing my washing machine, so why would I ask or follow advice from someone unqualified for advice on my cancer? I would always take advice from other sources with a good dose of skepticism. Again, do your own research on what you're told. Consult reputable sources of information and not the health section of the daily tabloid. Not your cousin who's heard from someone who works with them that had a friend whose uncle's wife's cousin took a potion prescribed by a healer in the Outer Hebrides. This is too important to rely on that kind of nonsense. Complementary is fine once you and your oncologist are in agreement. But remember, alternative medicine isn't actually medicine or an alternative to medicine. Things to consider before you make a decision are the risks and benefits of any treatment and what you expect the potential outcome could be. For a realistic perspective in this decision-making process, patients need to do some homework. Information is always at the center of this process. As my health improved, I became more proactive in my own care and I began attending conferences. I would understand the conclusion slides, but many of the graphs left me baffled and bewildered. I'd nod away in agreement to not really understand if this was beneficial or a load of baloney, to be honest. Swimmers' plots and waterfall graphs were my bugbears. And I'd try reading scientific papers. And after time, the more I practiced, the more it all sank in, like learning a new language, really. I asked a lot of questions, and I persevered because I didn't really see myself as having an alternative option. I was now at stage 4, and what I was learning was enabling me to have informed discussions with my oncologist and make decisions together. Of course, I do understand that this might not be for everyone to get so immersed, but it is important to have someone you can rely on to do it for you if you physically or mentally can't, or someone you can ask opinions of that's trustworthy. So this is Darren, and I needed help. And I needed somebody I could ask all my learner statistic questions to. I found him on Twitter, and it turned out that he's the chief statistician at the Health Research Board in Ireland. And in his spare time, he was running a workshop called Statistics for Citizens. So I joined up, and then we decided to do a workshop together for patients. And in the future, we hope to do more education programs for patients. This stuff is doable, and if I can learn it, then anybody really can. But we have to remember that even Darren once had to start at the beginning, and all of our oncologists were also freshers at one stage as well. If you ask the professionals, they're usually willing to help, and I guess that's why so many of them turn up every year at this conference, because they want to help us to understand. Me, I wanted to understand how the statistics gathered influenced what was being approved for patients. And although I made progress, and I'm now happy enough to read a scientific paper and can even evaluate it according to the ESMO medical scale of benefit, like some of us learned at a workshop last year, the more I learned, the more I wanted to learn, and hopefully use it to help patients starting out that needs direction to reliable sources of information, the ones that have just landed in that black hole that is a melanoma diagnosis. So before I attended large oncology conferences, I had never heard of the terms used like p-values or hazard ratios, censoring or events, which were often represented on the graphs by a little black triangle. Those were often skirted over in the large presentations, and now I know why. It's uncomfortable to talk about failures, especially when it comes to trial data. But these were real people that they were talking about, with hopes and dreams and families, just like us. And I've been on one of those graphs, and many of my good friends have also been. Patients, they contribute so much by becoming a trial participant. Other stakeholders often refer to it as being a choice to participate, but it's only ever a choice if you have a viable alternative, and as patients, we often don't. Sometimes the only choice is to do what is offered or else die. That's why it's so important that patients have their opinions represented in all aspects of drug development cycle. We're the ones with the most to lose. At conferences, I'd often end up asking a question just to remind the presenter the fact that the patients were there and we were now listening and learning something. And it wasn't always a great question, but sometimes I even got thanked afterwards by the attendees for reminding them of why they were there. And I know that one baffled me as well. I would have thought they knew why they were there. I truly believe it's vital that we can interpret the data because it affects not only the little life decisions like the chocolate bar or the muffin you want to eat until you read its recommended daily allowance label and realize it's really bad for you. Or if you should bring an umbrella on your walk today because it's a high percentage chance it will rain. They affect all of our major life decisions, and they can make a big difference in our survival chances. They empower us with knowledge to understand which information is most relevant when deciding a treatment, to push for drug reimbursements like the new adjuvant ones that we heard about this morning. They help us to decide, should I switch treatment now or should I wait? How are these treatments affecting the overall quality of my life? Understanding the statistics empowers us to know when we can say, hey, wait a minute, this trial just isn't good enough for patients and we're not going to support this. Understanding statistics help us collect and collate our own data which can be used to influence clinical trial design, HTA reimbursements, improve services, and most importantly, improve life expectancy and quality of life for patients. So remember, knowledge is power, and statistics can actually be pretty cool. I never thought I would say that. Once you get over the fear and do it anyway. That's it.